are at a fascinating place in American healthcare, historic place. We don't know what that history will be yet. It isn't written, but it will involve something different. Part of that is the new law, which I know you're all interested in, the Affordable Care Act. We celebrated the first anniversary of the Affordable Care Act in March. I can see from where I sit now, 10 months into the job, heading CMS, immense benefits to Americans. Seniors in our country are now able to get medicines that they couldn't have gotten before because we're beginning to close that donut hole in coverage in the Part D program. Preventive services are now covered. We have annual wellness visits now covered for seniors, including screening tests that are now first dollar covered. Kids under 26 can now get covered under their parents' insurance policies. I believe my own daughter, Becca, who's returning from going around the world with her boyfriend, will benefit from that through her mother's coverage in July. And we're, most importantly, expanding security. We're expanding coverage under Medicaid and setting up exchanges for people who aren't qualified for Medicaid but need some help finding health insurance. And we're writing a new set of regulations for the insurance industry that will make it impossible to deny someone coverage because of a pre-existing condition. I can't help reflecting on what it would have meant to my patient had he been sick now, because he would not have been able to, he would not have been uninsured. All of that's great. It's important. It's moral. It's a sign of a great country that we can now promise security more and more to our people. People won't wake up in the morning worried that they will go bankrupt from their healthcare costs, or that they won't be able to find insurance because they need it, or that their insurance will be withdrawn because they get sick. All the craziness that now is going to go away by 2014 if that law is effectively implemented as it will be. But we really need to look at that through a slightly different lens. Let's call that phase one. It's not over. It's continuing. Phase one is coverage. It's justice. It's getting people the health care they want and they need through promising coverage to our citizens. Phase one is not enough. And the reason is that it's not sustainable. And that has to do with a different set of issues than coverage. It has to do with the organization, delivery, configuration, performance of healthcare systems themselves. Systems that are not truly patient-centered, are not truly reliable or safe or effective, not as they could be, not as the science and facts know us to tell us how to make them. The care we have today, it's fragmented, it's far too costly. It wastes the time and energy of the good people giving care and the time and energy and money of those who seek and support care. From your point of view, it has another important defect, which is it too much divides the mind from the body. I don't need to tell you the statistics. Mental illness is more common than heart disease and cancer combined. 1 in 5 American adults has a mental disorder, behavioral health problem that's serious. 11 million suffer from very serious mental illnesses. Among serious mental illness, substance abuse is far more common than when mental illness is not the substrate. Life expectancy for people with major mental illness is 56 years in a country where our life expectancy overall is 78 years. The burden on the healthcare system of the sector you care about is enormous. It accounts for 15% of the total economic burden of all the disease in the U.S. It costs us tens of millions of dollars a year. And you know, as for the patient I described to you with leukemia, there's a connection between behavioral health and physical well-being. People with diabetes who also have depression are 60% more expensive to treat than people who have only diabetes without depression. Phase 2 of the healthcare change that we need is to make phase 1 sustainable. It's to make equity and security and coverage sustainable for the long haul, for current beneficiaries in Medicare and Medicaid, and for the future ones. How will we do that? Well, the answer I've got is actually pretty simple to say, hard to do, but simple to say. The way to do that is to improve care. In CMS, we're now using a framework from my past, the three-part aim, triple aim: better care, better health, and lower cost. Not lower cost by withholding care from anyone, not by harming a hair on anyone's head. It's better care, better health, and lower cost through improvement of care. I couldn't overstate the importance, if you care about healthcare in our country, about the need to embrace this idea of improvement. If we don't improve the system of care, we cannot afford the system of care. It's that simple. I love your theme for this meeting, Be the Change. It is about change, and let's talk a little bit more about what that means for you and for me. The good news is, from where I sit, the tools for change are in our hands. They are largely embedded in the Affordable Care Act, a widely underestimated law in the public discourse, if you ask me. It's an incredible piece of legislation. It has embedded in it enormous amounts of opportunity. It's like discovering this big toolkit with which we can build almost anything we want as a nation. It's an on-ramp for excellence if we choose to make it so. If it's used well, it's a door to phase 2. The stakes are extremely high. Let me explain the stakes. I think our country is now facing a choice. I don't want to overstate it, but it looks pretty clear between two strategies. The strategies are the strategies we need to get healthcare sustainable, to get costs under control, so we're not mortgaging our country's future economically, the well-being of our children, and our current seniors. And both strategies would work in a way. The first strategy is to cut. It's to remove. It's to take away, to decrease the number of people who are entitled to Medicare and Medicaid, to decrease the benefits they have, to restrict. That's one way to cut. It's the easiest way to cut. If you're in trouble, cut the budget. And there is a very, very strongly articulated wave of policy proposals in this country. You can see them at the state and the federal level to deal with sustainability of healthcare that way, by cutting healthcare, by taking things away. I think it's wrong. I think it's wrong, but you can't just say that. You have to have a counter proposal, because the cutting strategy is addressing a very serious social need, which is sustainability of our, not just of healthcare, but of our economy, our country's well-being. Strategy 2 is the one I prefer, I urge, I believe in, and that's change. Change the way you do the work. I'm not for cutting, I'm for changing. Lowering costs by cutting or withholding care for patients, it's bad. It's bad for patients, it's bad for families, it's bad for communities, it's bad for business, it's bad for our nation in the long run, and it is unnecessary. It is unnecessary if we change. We have to think about that change. I'll say first, no one agency, no one profession, no stakeholder, no leader, no one alone has in his or her hands the opportunity to change healthcare for the better. That opportunity can be taken only one way, together, only together. In phase 2, the phase of changing care for the better, we're all in this together. Partnering is everything. I will say you are critical because you're the ones who give the care. You are affected by the decisions that we make. You are the only pathway to better care. It's through you and your goodwill and your intentions and your willingness to engage that we find the hope to avoid that other plan, that cutting plan. At CMS, our job is to make it feasible, possible, more and more attractive for you and your other colleagues in the delivery of all forms of health care to improve your care, to pursue the three-part aim: better care, better health, and lower costs through improvement. We need to ask of every regulation, every program, every innovation, how it will encourage and support or impede physicians and nurses and psychologists and social workers in hospitals and others to provide better care at lower cost. Our mission now in CMS, since I've arrived, our mission statement is this: to be a major force and a trustworthy partner for the continual improvement of health and health care for all Americans. A major force, proactive, trustworthy partner, we're in this together, for the continual improvement, not minimal thinking, aspiration of health and healthcare, both, for all Americans, not just the beneficiaries we serve, because we couldn't change care for the 100 million people in Medicare, Medicaid, and CHIP and leave the rest of the system unaddressed. That would be ridiculous. Lots is going on in pursuit of this. As stormy as the debate is, as tough as it feels out there, I have never felt more sense of possibility than I feel now about the chance to actually recraft the care we want. And there are several examples in play, which I'll describe for you briefly. I could go on much more time than I have or you have, but let's look at someone. Say, accountable care organizations. What's that about? If you think about the improvement of care, it seems to be to come in sort of three buckets. One bucket is safer care, more effective care. My patient, his name was Malachi, was almost killed in the hospital by a medication error during his leukemia treatment. He got a medicine to which he was allergic and had a cardiac arrest. He was resuscitated and survived to have his leukemia cured. That was unnecessary. That's a defect in the delivery of care itself. We'll come back to that later. That's when you're in the care system. That's bucket one. Bucket two is the kind of care that kid needed over time and space. As he journeyed among institutions and facilities and specialists, as he went from in and out of hospital to home to rehab, as he needed home health nursing and psychiatric support. That's journeys. That's about care over time and space. The third bucket is the community itself, which is how to embed healthy behavior and practice in the community. And that's the way I'm thinking strategically now. Better care, seamless care, and healthy communities. Accountable care organizations are about that in vast middle terrain, the seamlessness of care. It's a very important area of improvement. I would say the bulk of the improvements we have accessible in healthcare and the bulk of the waste that we can recover to make healthcare more sustainable lie in the seamlessness that we could build if we really were about seamlessness instead of fragments in healthcare. The Accountable Care Organization is an element within the Affordable Care Act designed to help our country foster, birth, coordinated care systems in a fee-for-service context. That sounds almost oxymoronic, because most of the way we think about coordinated care is to set up a restricted system, a closed network. That's not what accountable care organizations are about. Accountable care organizations are contemplated to be organizations that are truly patient-centered. They're about the primary care base and home of the patient, and they're rooted in primary care, which is the home of the journey for people through their time and space. They're held accountable for what happens to the populations of people attributed to them. Accountable in quality terms and accountable financially. Indeed, if they reduce the costs of care for a group of patients while making their care better, they can share in some of those savings. And they exist in an environment in which the patient's choice is not limited. The patient can go anywhere he or she wishes, just like any other patient in Medicare Part A and B. It's a very bold idea, and we've now issued a proposed rule. The notice of proposed rulemaking is out about what this kind of beast could look like. The comments are due by June 6th. I'm interested in the comments that we'll get from all the players in healthcare. Every sector should feed back what they think of our first try. The final rule will be better than the proposed rule. It'll be better because we'll change it to be better. But to change it to be better, we need the help of the community to tell us what we missed and what we got right. I would say for you in the behavioral health world, it's really important for you to speak up about this, because we've got to find a way to reintegrate behavioral health and the care of populations. And I think looking at that proposed rule and commenting would be very helpful to us. That's one kind of move in the Affordable Care Act toward creating seamlessness and continuity. There's another gift in the Affordable Care Act. It's the Center for Medicare and Medicaid Innovation. And again, I think it has a lot to do with behavioral health in your sector. What Congress did was set up a new center, reports to me, with $10 billion of funds set aside, allocated already, over a 10-year period, to foster invention, creation, new ways to organize, deliver, and pay for care. And the Innovation Center has lots of range and latitude. It can do things, it has the authority to do things that are not customary in the Medicare program and Medicaid. It's a Medicare and Medicaid Center. Its job is to deliver on the three-part aim: better care, better health, and lower cost. But all of that, at least better care and lower cost at the same time. If the center discovers and proves with the Office of the Actuary that an innovation does that, makes care better and reduces cost, it can remand that finding to the Secretary, who can then translate that into rulemaking without going back to Congress. It's a very bold and exciting notion to speed innovation into practice. As I said earlier, I'm anxious to have the Innovation Center focus its energies on those three buckets: better care of individuals, safer care, more effective care, care that doesn't subject patients to harm and gives them a chance at the best possible outcomes. Seamless coordinated care, well beyond ACOs, all the things we could do to make care get better. I was talking to Linda this morning about this issue of cooperation between FQHCs and behavioral health centers. I'm pretty excited by that idea. I think if you think about the nexus, I thought they were working together a lot. It sounds like there's more to do. That would be an area of seamless care. And then community and population health upstream, working really on the root causes of the illnesses you and I face. So the Innovation Center is going to be offering opportunities. Its programs will be announced quite soon for more participation in the national expedition toward finding better care. A third area of work beyond ACOs and the Innovation Center, but very closely related to the Innovation Center, is work with dual eligibles. That's a population of great importance to you. People eligible for Medicare and Medicaid both, and that's because they have very special needs. There are only 9.2 million duals in our country. They take 40% of the Medicaid budgets in our country, 40% of the state Medicaid budgets. And ask any governor in the country what they're worried about. They'll talk about Medicaid. 40% of the costs are related to only those 9.2 million people. We estimate that only about 100,000 of the 9.2 million are actually in the kind of integrated, coordinated care that they want and need, or the kind of care that creates journeys instead of fragments. And so Congress set up a new center, the Federal Coordinated Healthcare Office. I call it the Duals Office, headed by a remarkable woman named Melanie Bella, whose job is to figure out how better to craft journeys for dual eligibles, which will involve changes in payment and organization of care and the fostering of lots of innovation. Very exciting area. And again, that office is going to be issuing more and more opportunities over the next months. We just gave awards of $1 million each to 15 states, which applied for those awards to plan state-level activities to improve care and create new forms of delivery of care for dual eligibles. Very exciting area. So we have ACOs, we have the Center for Medicare and Medicaid Innovation, we have work with dual eligibles, we have the related work on medical homes and health homes, new forms of thinking about how orchestration of care through a primary care or community-based entity can help people find homes, find home plate, home base, to help them get their care organized with professionals, and I think to stay in control of their own care instead of being buffeted by a very complex system of handoffs. Very importantly, very excitingly, and I think related to your work, is patient safety. The Secretary of Health and Human Services, Kathleen Sebelius, and I 3 weeks ago, launched the largest effort in the history of our nation, I think of the world, in trying to make care safer. Patient safety is a very important arena. We have enormous evidence that people get hurt in the care system that seeks to help them. We don't know in detail how this interacts with the work you're doing in community behavioral health, but it's worth thinking about. Most of the evidence is about hospitals. The Office of the Inspector General in HHS in October issued a report which was a study of care of about 750 Medicare beneficiaries in hospitals. It found that 13.5% of those people had suffered a serious medical injury during their hospital stay, something like a medication mishap or a ventilator pneumonia or an infected central venous line or a pressure ulcer or a postoperative complication or a wound infection. 13.5%, at least half of them preventable, costing immense amounts of money, but also causing immense amount of suffering and anguish that is avoidable in that population. 22% of chronically ill adults report an error in their care in the prior year. And last month, an article in Health Affairs appeared in an issue focused on quality that reported that the injury rate for American patients in hospitals looks to be about 1 in 3. About 1 in 3 patients are injured by their care. This is a stunning problem. It's not so surprising if I just ask you here, how many of you know a loved one, a friend, a relative, yourself, who had an encounter with healthcare, maybe in a hospital, and was injured, a medication error, a complication? Raise your hand if that. You see, every hand's up practically. So it's familiar part of our experience, but you're not alone with it. Our country has a problem. It's not, and let me repeat that, it is not to call into question the goodwill or the commitment of the healthcare workforce. People are trying every day as hard as they can to keep patients safe. But the same fragmentation that leads to discontinuous journeys for patients, the same fragmentation that allowed that patient to get a drug that he was allergic to, the same fragmentation is embedded in the healthcare delivery system, and that's what traps the nurse or the doctor or the therapist in an error that they didn't mean to cause. We can get out of that. We know we can get out of it. We have examples all over this country of tremendous progress making patients safer. Hospitals that have eliminated central line infections, eliminated ventilator pneumonias, cut surgical complications by 60 or 70%, cut unnecessary readmissions to hospital by 80%. The examples are everywhere. The problem is they're still in pockets everywhere. Individual hospitals, individual successes. It's time to go to scale, and that's what this project, the Partnership for Patients it's called, is about. The CMS, the Innovation Center, is taking $1 billion and putting $1 billion into play all over the country with supports to hospitals and clinics and doctors and nurses to help them make their care safer, and we're going to knock the socks off this. Our aims are, thank you. Our aims are 40% decline in hospital-acquired conditions, complications by 2013, and a 20% decline in readmissions. You can play in both those arenas, by the way. Behavioral health, I think you have a lot to offer in keeping people home where they want to be instead of bouncing in and out of hospitals. And it will save money. We estimate $35 billion over the next 3 years saved for the healthcare system as a whole, $10 billion for Medicare. What it takes is what it always takes for change. It takes will. We have to decide to do it. We have to decide to be a system in which medication errors and pressure ulcers and ventilator pneumonias and surgical site infections will just not be there. We know how to eliminate. Will. We need the ideas. We need to know how it is that Centara Norfolk Hospital has gone 5 years without a central line infection, how Seton System in Austin, Texas has 10,000 consecutive births last year with only one perinatal injury. We have to know how readmissions have been cut by 60 or 70%, how National Children's Hospital in Columbus, Ohio, where I just was, has cut surgical infections and complications by 60%. We have to know how they do it, and then we have to bring that excellence to full scale. And that really is the problem writ large. It's not just about safety. It's not just about patient-centeredness. It's not just about chronic disease management or even prevention. It's taking what we know as a nation and bringing it to scale. It's making the best the norm. In your area, it could not be more important. Taking what we understand about the best wedding of behavioral health and physical health, following the pioneers, Doug Eby at South Central Foundation up there in Anchorage with his colleagues in South Central, wedding behavioral health and physical health in team-based care, stunning results in reduction of the need for care, saving money, saving lives, saving well-being, and keeping people home and healthy and well. Those examples are not rare, they're abundant. We're in this together. The job we have now, boards, clinical leaders, executives, professionals of all types, hospitals, the ambulatory sector, we're in this together. We need the energy to decide that it's time for our country to make excellence the norm, to build on what we know, and to make the best care the only care. If we do that, we can avoid that tragic decision to cut. We have a choice. The choice is cut or change. I'm for change, and it appears so are you. Let's stay in this together. Thank you very much.